Hello, everybody. My name is Hugo Verreke. I will present a lecture on pharmacology, how it can become a guide for your anesthetic management, and more specifically, I will talk about Smart Pilot View, which can be seen as the anesthesia global positioning system. I prepared this lecture originally for the Koreanesthesia 2024, but I think the information of this lecture could also be of interest for other anesthetists, especially those who consider to work with Smart Pilot View. I have no conflicts of interest, no shares or any financial benefits. I served as the president of the ISEP and I'm the current lead of the subcommittee pharmacology at the ESAIC. Just a map to show you that the University of Groningen is completely in the north of the Netherlands, whereas I now currently spend most of my time in the General Hospital AZ Sint-Jan in Bruges in Belgium. Why would we talk about pharmacology to predict anesthetic effects? Well, first of all, because pharmacology is the science of a mathematical description between the relationship between a drug dose and the time course of a clinical effect. And then we focus mainly on onset and elimination times. The utility is perceived by some as limited for clinical practice, and that's mainly because the pharmacokinetic dynamic models predict only population average effects and the estimated average time course of drug effect. So it only provides kind of a GPS map, but the clinicians, they prefer to titrate the individual effect and respond to excessive or insufficient drug amounts. So they would like to know the optimal road for each individual to get on their goals fast. But the good thing about having a map in advance is that it provides you proactive information even before any drug is being administered. The challenge for using pharmacology to describe the anesthetic state is that it's a quite complex state because it has either a hypnotic component, which is mainly mediated through neural networks at a higher cortical level. And in clinical practice, we evaluate that by looking at the loss of memory formation and loss of response to verbal command. And of course, we use hypnotic drugs to control these clinical effects. At the other branch of the tree, we have the balance between nociception and anti-nociception, which is clinically evaluated by loss of response to noxious stimulus. And the neural networks involved are mainly located at lower cortical structures or brainstem and spinal structures. So how do we evaluate? There are clinical signs like an EEG arousal, sudden movement, or a disruption of the auto and parasympathetic nerve system that can warn us of an insufficient analgesia. And we try to control these effects using opioids or added local regional techniques and adjuvant drugs. If we want to describe the complexity of anesthesia, like I described in the former slide, we need to start with the basics. And by that I mean we first have to get some control over the relationship between a single drug and its representative effect. And I've made this small visual illustration where you can see how a three-compartmental model describes the EEG effect in relation to the dose of propofol using the Schneider model. This is just as an example of how we can do this for one drug. This is an example of the pharmacokinetic dynamic model described by Schneider, a model that was developed to describe the pharmacokinetics and dynamics of propofol in the lean adult and elderly population. The model exists out of three connected volumes of distribution with an added effect site concentration that represents the EEG effect. The model also shows the elimination path of the central compartment towards the other volumes and the terminal elimination. We now can calculate the exact values of the volumes of distribution and the elimination constants by adding the demographic information of the patient so that the model can predict the average time course of propofol concentrations in a similar patient. Using these variables, Let us assume a bolus dose of 2 milligrams per kilogram administered into the model in the central compartment. We will initially see a steep rise in the plasma concentration, followed, with some delay, by a steep rise in the effect site concentration towards the peak effect. After that phase, there will be an initial steep decay of plasma concentration, and the effect site concentration will also decrease, but a bit slower. In case we want to maintain a steady state of effect, we need to add a continuous infusion of propofol at 6 milligrams per kilogram per hour in this case, and then this will lead to a slow equilibration between your plasma concentration and your effect site concentration into a steady state. The model at that time predicts a steady clinical effect. On a pharmacokinetic level, there's not yet a steady state because the compartments need many more hours of drug administration to be filled up, and the longer we give drug administration, the more accumulation you will see as predicted by the model. I hope you all enjoyed this small animation on how a simple three-compartmental model is able to tell you something about the onset and offset of a single drug effect. But how should we use this in clinical practice? Because even though that we now have an effect site concentration of propofol, for example, showing you that 5 micrograms per milliliter represents an average BIS of 50 in the population, we still know that there is residual uncertainty. There still are patients that are more resistant than others who are more sensitive, and they will not reach or will not behave according to the average. How should we interpret this? The answer to that question is that despite that a single effect site concentration only predicts the average BIS of 50, and that some patients will be more resistant, for example, this patient with a BIS of 90, and others will be more sensitive, like this patient who ends up with a BIS of 27 with the same effect site concentration. Look at the total population. The majority of that population has a BIS that reaches a clinical acceptable value between 40 and 60. And that is, of course, because the majority of endpoints in the nature are bell-shaped organized. So even if you set a single target of your effect site concentration to reach an average BIS of 50 in the population, the majority of that population will probably be between 40 and 60, which is a clinical acceptable and predictable anesthesia result. And this is how we will use these pharmacological models time after time. And there is some evidence in it that this indeed is the case. For example, in this study, it's an older study, but we have done many studies where we use TCI, effect site control TCI, with the same result, where you see that if you compare a plasma control TCI, which is already adapted to demographic variability to maintain a steady plasma concentration, on the effect site level, you see that the time of loss of consciousness is very unpredictable. There's even one who only loses consciousness after 10 minutes. And also the variability in the BIS values is large, pretty large, and a large number of outliers are still present. But if you titrate to the effect site concentration, you see that the loss of consciousness, the time to loss of consciousness is much more predictable. And even after some time, the variability in the BIS is lower, and the majority of that population indeed has a BIS between 40 and 60, where we titrated an effect site concentration of 5. Now that we have a tool for single drug effect control, it's the effect site concentration, we can spice things up by combining different drugs. And in a normal sigmoidal Emax curve, you see the relationship between a low dose where there's no effect, a low dose where there's no effect, a high dose with maximum effect, and if you titrate to half maximum effect, you define the EC50, which is a measure of potency of the drug. And then you only need the slope of the curve to define the total dose response relationship. We can do this for the two single drugs added in this model. They are to the sides here, And then you can start combining drug A and B in different ratios, and for each ratio you can define a new sigmoidal Emax, leading to this three-dimensional representation of the relationship between two drugs and a clinical effect. If you look at this response surface model from the upside down and you make a slice at the level of the EC50, you see the classical isoboles, which are lines of equipotent effect between combinations of drug B and drug A. The shape of that line of that isobole determines whether it's a synergistic interaction. If it's a straight line, it's an additive interaction. If it's a concave curve, then it is a infra-additive interaction. In the anesthetic literature, in the anesthetic pharmacology literature, many research groups, for example this study by Bouillon, started to combine effect site controlled combinations of remifentanil, propofol and different other anesthetic drugs in order to create the response surface models for specific effects, such as the tolerance of laryngoscopy. So to do so, you titrate different patients towards different combinations. The circles are patients who still responded to laryngoscopy. The triangles are the non-responders to laryngoscopy. We could also develop such response surface models using tolerance of shake and shout. And such studies already provided many useful clinical information. For example, these graphs reveal that if you target 4 nanograms per milliliter of remifentanil and combine this with 4 micrograms per milliliter of propofol, then you reach a little more than the tolerance of laryngoscopy, 90%, and the BIS will be a 45. So on average in the population. Of course, you might need to adapt a little in some patients, but the majority of the patients will have a predictable effect close to the tolerance of 90% and with a BIS of 45. So this is a useful combination to start your induction. But it becomes even more useful when you start looking at the volatile worlds and combine sevoflurane with remifentanil using the same clinical effects. We looked also for tolerance of laryngoscopy, tolerance of shake and shout. This is the research group of Ghent where I worked at the time. And also these models revealed very interesting information on the difference between total intravenous anesthesia and volatile agents. For example, as you can see, if we titrate the same amount of remifentanil as in the previous example, and we titrate towards a BIS of 45, so then we can conclude two things. First of all, you need less sevoflurane than what you would generally give in a clinical anesthesia setting. It's only 1.7% volume percent and tidal. And what you see is that the distance with the tolerance laryngoscopy 90% isobole is much larger. So if you target to the same BIS using volatile agents with the same remifentanil combination, the probability that your patient will move with the volatile agents is less than with the total intravenous anesthesia. That's what the models predict. But can we expect of every anesthetist to really dive into the many publications related to interaction models and combining all kinds of different drugs that we use in clinical practice? And there even is more where that came from. So the question is, how are we going to integrate all this literature, all this information into a system that gives us a simple, intuitive advice on how to titrate our drugs, depending on the demographics and depending on the selection of drugs we prefer? The answer to that question is that we develop an advisory screen, single advisory screen that integrates both the demographic information of the patient, the dose and the timing of the drug administration, applies this in the existing pharmacokinetic dynamic models to calculate their respective effect site concentrations, and use that as an input to develop interaction models at the bedside of the patient, with the intention to have a single predicted effect as an output, which is selected as being the probability of tolerance of laryngoscopy. And why did we select the probability of tolerance of laryngoscopy? Because it's a very similar concept to MAC. MAC is a predicted risk of motoric response after incision, whereas I think even it's better than MAC, because MAC is only valid when the volatile agents are used alone. But in our system, with the probability of tolerance of laryngoscopy, the effects of different volatile agents, nitrous oxide, propofol, and multiple opioids are integrated into that single number. So we have developed a new measure of drug potency, not only of a single drug, but of a mixture of anesthetic drugs. And that's defined as the p-tol, the probability of tolerance of laryngoscopy, or an inverse derivative from that, which is called the noxious stimulus response index. This noxious stimulus response index relates to the probability of tolerance of laryngoscopy according to this formula. So as you can see that the NSRI is a direct derivative of the inverse of the p-tol. The reason why we've developed this new index is because it can represent kind of depth of anesthesia index related or derived from pharmacological input alone. Also, it's not a linear relationship, because then we have some more descriptive capacity between 20 and 80% of tolerance of laryngoscopy. Just to keep in mind that if you titrate towards a p-tol of 0.5, that corresponds to an NSRI of 50, whereas a tolerance of 90% tolerance of laryngoscopy represents an NSRI of 20. And this is how the interface will look like. Let me present to you the Smart Pilot view. This is the total screen where you can see different parts, and one is of course the availability of the demographics of your individual patient. Secondly, you see a time-based graph where there's a cursor indicating the current time point. There is a bit that shows you the past, a bit that shows you the future if you do not change any of the drug administrations. And here the different effect site concentrations for each separate drug is being calculated. You can put the drug dose and timing in a manual way on the time bar to calculate your corresponding effect site concentration, or the system can be connected to infusion pumps and the ventilators, such that the effect site concentration of volatile agents and of your drugs that you give by pump can be automatically included into the calculations. Also, during the case, you can mark certain events if you want to use this system, for example, for research, loss of consciousness, intubation, incision, movement, a sudden movement that is happening, extubation, or you could add other events if you want to plot them on that screen. So here you also see that there's a time cursor who indicates the current situation, and that also represents the numbers of your effect site here. And then you have this previous history of your drug titration and what will the future offer when you do not change your current settings of your drug administration. And also there's this two-dimensional graph which represents the different isoballs from the interaction models. And the upper curve, the dark gray curve, is the tolerance of laryngoscopy 90%, which represents an NSRI of 20. If you titrate 100 patients to a place on this line, in theory 10% of them might still have a movement response at laryngoscopy, but 90% of them will not. The lower dark line represents the 50% tolerance of laryngoscopy. The light gray upper line is the 90% tolerance of shake and shout, and the lower light gray line is the tolerance of shake and shout 50%. So this lower line could be an interesting target for waking up the patients. It is the idea that above the isoballs on the two-dimensional screen, that all the opioids administered will be recalculated to remifentanil equivalents, and that in the y-axis either a propofol or sevoflurane y-axis will be shown, and you can so express your hypnotic effect also in terms of effect site concentration of the hypnotic drugs. The case will be plotted on that line, and I will show you a video in a minute which shows this much more clearly. Also on the other side you see a time-based plot of the noxious stimulus response index. Why is this? This represents a kind of depth of anesthesia based on pharmacological endpoints alone, and it helps you to keep your equipotency in your total drug mixture when you start shifting between drugs. I've constructed a small animation video that shows you how the plot is being developed over a case, and it shows you several options of how you could interpret the Smart Pilot view in clinical practice. I hope you all enjoyed that small animation video. I just want to show this slide because there's a second version of the Smart Pilot View that is integrated in the Zeus ventilator. It's a smaller fraction of the screen, so there are limited numbers of drugs shown on the screen, although you can calculate the same number of drugs and the calculations didn't change. But the important thing is that you see the two-dimensional graph and the NSRI over time in the same interface. Of course, there are limitations to this Smart Pilot View, and the most important one is that the predictions of effect by the Smart Pilot View are limited to the demographic ranges used for developing the pharmacokinetic models of Schneider and Minto, for example, for propofol and Remy, but also for the other drugs. And I would say in general that the current population where we can use Smart Pilot View are the lean adult patients and elderly patients. There's more of a problem for, there's no option for pediatric patients and obese patients. One might be careful not to exceed the ranges of the demographics of the models. Another limitation is that it allows manual input, so if you make a mistake in timing or dose, of course the calculations will be wrong. But even with the automatic registration, we have seen that some infusion pumps give a low resolution of data towards the system, which also may lead to inaccurate calculations. Then also what I find important is that you should realize that the interaction models also have a degree of uncertainty, and so this is not depicted on the interaction model 2D screen. We have to realize that in the middle of the elbow of the isoballs, the resolution of information is highest, and so the uncertainty of the predictions of the model at the extremes of the isoballs are less certain. And then also there are no ranges defined what the optimal NSRI or PTOL should be. And that is of course very similar to the MAC concept. I'm not going to tell you that you need to titrate all your patients between 0.7 and 1 MAC, because you know that is depending on your goals of clinical effect, your comorbidity of the patient, the type of surgery, and so on. So this is just a reference of what you can expect in a similar patient as your current case, but it's not something that is obliging you to titrate in a certain range. And on the other hand, Smart Pilot View creates a new dimension of value, because it of course has a tremendous educational value. It shows you very intuitively what you are doing when you combine certain drugs, and also you build confidence on titration in a certain combination of volatiles, propofol, and opioids. It can help to leave your comfort zone of what you have learned on your experience-based use of drug combinations and evolve towards a more evidence-based titration. So it's an intuitive interface that turns the anesthetist into a smarter pilot. What also is a very big advantage is that you do not need a TCI pump to have the output of the models. You can, for example, in the USA, where the effect site concept is not approved by the FDA, you can really use it in a normal titration of boluses and continuous infusion to help you out to get an idea of what the potency of your drug mixture represents. Now is the question, if you use this new device, will it improve, for example, the reproducibility of your recovery times, and will it improve outcome? There have been several outcome studies that were published, and this is one of our own research group, where we had a large bi-center study both in Groningen as in Bern in Switzerland, where we had a control phase where all the normal clinical behavior of our colleagues was registered, and after short training with Smart Pilot View, we also looked at how this affected their titration skills. In both phases, we only looked at surgery that lasted for more than 1.5 hours. The anesthesia management was to the discretion of the anesthetists in both groups. The demographics, all drug dosing and timing in the control group was collected using a software package, and BIS was used but was blinded for the clinician. And of course, MAP and heart rate was not blinded. During the study group, we allowed to use the Smart Pilot view to optimize the drug titration. We didn't really push them towards a certain advice. We only explained what the isobols meant and what the information was. All the events of movement or intubation and so on was registered by an investigator who was present with all the cases. And the BIS monitoring again was blinded, so that's an interesting comparison between both. In total, 170 patients were included in the control group and 188 in the Smart Pilot view, which is quite a big study. The primary research question was whether the anesthesia quality score was significantly affected by using Smart Pilot view. And the anesthesia quality score was a composite index which represents the percentage of your total case time, which means between incision and end of surgery, that both the BIS and the MAP were in the desired ranges. And for BIS that was defined between 40 and 60, and for MAP between 60 and 80 millimeters of mercury. So it's a measure of simultaneous hemodynamic stability and adequate hypnotic drug effect over time. The secondary endpoints focused on intraoperative differences between drug uses, the area under the curve for deviations above or below the threshold of the MAP and the BIS, and also we had some post-operative outcomes that we controlled, like pain scores and post-operative nausea and vomiting, and we looked at interdepartmental differences. Because the Smart Pilot View study was a very tough study on technical challenges and had many technical challenges, we kept it in one operation room, so that led to the fact that almost exclusively gynecological surgery was performed there, and so the majority of our patients were female. There was a reasonable age variability in the population, but the BMI variability was limited. So not that much of a high-risk population, it was rather a low-risk population with limited demographic variability. The primary outcome was not significantly different. But what was surprising is that it was quite tough to keep both the BIS, which was blinded, or the MAP, which was obviously unblinded, within the desired range. And that was a bit of a surprise to us. So this is a graphical representation of the main outcome measures, being the MAP and the BIS. The red color is all the cases which were in the Smart Pilot View group, and the blue, which is maybe less clear on your screen, is the control patients. And if you take the confidence intervals and the median of all these values, you see that in the majority of cases, the patients were kept at a higher blood pressure than what we aimed for in our study. That's why we had such a low AQS. The BIS was clearly lower in the control group compared to the Smart Pilot View group. So apparently we gained some depth of anesthesia or excess in propofol. The main conclusions of the secondary outcome was that the area under the curve for hypotension and for low BIS were significantly larger in the control group versus the Smart Pilot View. That effect was mainly seen in Groningen, where apparently the titration of the MAP especially was a bit more tight compared to the Bern group. Time to extubation was on average 2 minutes less in the Smart Pilot View versus control, but especially in Bern, where they seem to adhere to the isobol information more accurately compared to in Groningen, the recovery speeded up with 6 minutes. So that's a very significant effect. For the post-operative outcome parameters, we see similar low pain scores. There were effective pain control in both the Smart Pilot view as in the control group. So then it's tough to have a significant difference. The pain scores were not worse, at least, by diminishing the anesthetic depth. There was a similar need for analgesics post-operatively and similar incidence of nausea and vomiting. It seems that when you use the Smart Pilot view, there's a tendency to decrease the effect site concentration of propofol sooner compared to not using Smart Pilot view. And also we saw that there was a more effective loading dose of opioids towards the end of surgery, because the model clearly predicted that remifentanil was already very low or there was no residual analgesia foreseen. There are some other outcome studies which I will be very short about. This one did not show a very significant difference between a BIS controlled group and a BIS plus Smart Pilot view controlled group, also in a low risk gynecological population, not much difference. This study showed a difference, but again, the BIS was unblinded, and then there was a faster extubation, a faster recovery to Aldrete score, lower propofol and remifentanil consumption. But again, is this an effect of the BIS or is this an effect of Smart Pilot view? Needs to be seen. And this is a very interesting study because it shows that in high-risk elderly patients getting a hip fracture surgery, there was not only an improved faster recovery, less intraoperative hypotension, but also a shorter hospital stay. And that's quite an important improvement. In this best abstract prize winning poster that we brought to the Koreanesthesia 2013, we demonstrated also that despite that the NSRI is adaptive anesthesia indicator solely depending on pharmacological endpoints, the predictive performance was very high, even higher than some EEG-derived R indices such as the BIS and the spectral entropy. Having said all this, my final conclusions are that the Smart Pilot view provides an advisory roadmap and demographically adjusted GPS signal, helping to navigate the complexity of anesthetic pharmacology during surgery, makes anesthetists to smarter pilots within the spectrum of balanced anesthesia. The quantification of NSRI opens new opportunities for comparing balanced anesthesia strategies and also strategies between centers. And outcome studies suggest advantages mainly in recovery time and reduction or optimized timing of drug use. And that depends on the studied population and the level of adherence to the information of SPV. I thank you for your attention and I'm looking forward to your questions.